factors? What are those things that could increase someone's chances of getting these brain masses or brain tumors? And maybe to take us through that will be Dr. Juliet. Yes. So Dr. Juliet, yes, what are the risk factors for these brain masses?
So thank you very much, Dr. Sechanze. Of course, most of the times we think that the same way the other cancers occur, the risk factors for most of the other cancers may be the same risk factors. So we look at things like smoking, looking at things like alcohol use, though those can't point exactly to where, unless if you're saying that they are sending something from elsewhere to the brain. Now, when it comes to the brain, remember we talked about genetics. In fact, part of the classification currently includes those genetics. One of the things I talked about earlier was that there are those people that have lesions on the skin, like there are those swellings. In fact, some of them have them all over. And so most of these have either brought in a child or come with a swelling that is related to a nerve, what we usually call neurofibromatosis. And then there are people who either have something that changed within the particular genetics. There are several genetics that we look at that are associated with several brain tumors. And even as we classify the tumors now, you'll find that this is associated with that. For example, there are people whom we've seen have a breast cancer, and then they also have a tumor in the brain. This is common, of course, in women. For example, when we talked about the low grade or the non-cancerous tumors like a meningioma, because they are related to hormones. So you may find that a woman has a hormone-related breast cancer, and then the risk might be the same as getting something in their brain. And then there are people who had radiation when they were younger. There are children who will radiate for brain tumors. So they may get a secondary tumor from the radiation. Of course, radiation doesn't stop at just tumor radiation, but there are so many radiations around us. Some are in the cars, some are like there's radiation that we may not even understand that's around us.
Including the sunshine itself.
The sunshine itself. And then there are at times when we talk about mobile phones, I think it's been more studied abroad than here. But we tend to think that our phones probably carry a bit of radiation that may affect us in the long run. For example, when a patient gets a head injury, we tend to tell them to get away from the phone because there's something that phone will do to the brain. So we tend to think that this might also predispose someone to a brain tumor. And then there are people who've talked about previous head trauma. So you get a head injury, and then from there, the process just continues on until you form the brain tumor. And then, of course, sometimes we don't know. So in as much as people might spell out, okay, this, all that, sometimes we don't know what may cause these brain tumors. Yes.
Is that what they would call idiopathic?
Exactly.
Whereby you cannot find a cause?
Exactly.
Wow.
So sometimes we just don't know. And then the others, I believe they are going to be found out even more, because when we run to the newer classification of the brain tumors, it goes beyond the World Health Organization classification. So now the genetics are actually helping us classify who and who is at risk. So that one may even get us to know that if I find that so-and-so had it and they come from this family, then it is likely that when we see the other people in the same family, they may get it. So what we'd call a genetic or a family history.
Okay. Well, thank you very much, Doctor, for taking us through those risk factors. Yes, you've mentioned about radiations, and surely radiations are everywhere. People are working in factories, sometimes these emit radiations, and maybe all this could be affecting our people. So maybe from there we shall go to Dr. Okirol to tell us a little bit about the signs and symptoms. Okay, so people who have these masses, how do they present in a clinical setting?
Oh, that's great. So when you're looking at signs and symptoms of what and how this patient present, it is a plethora of symptoms, but you should be able to take a very sufficient history to help you try to localize probably where the issues are arising from. Because, as we said, wherever there's tissue, a tissue can change and change into a tumor. So every other tissue you have involving the different parts of brain structures, the brain parenchyma itself, the many what you'd call the layers surrounding the brain or the sac surrounding the brain. You have the thing that produce CSF that the brain bathes in, also having its own what on tissue. Each of these can change to have a tumor. So you find the ones having meninges, every place where there is a meninge, you're going to find, like, if it is in the anterior part of the brain, your executive thinking, interpretation can change. You have starting unaltered, confused kind of conversation. Then commonly some tumors will give you seizures, what commonly a person calls okwesika, something like jankubye, you understand? Or even blackouts. That's a common thing. Then you also have to find out that some people who, what you'd call a focal neurological deficit, like you develop weakness, you no longer have power in your hands or your legs. Depends on where it's located. It could have, because your entire body is mapped out on the what?
The brain.
On the brain. So if you find it mapped out on the brain, if it affects that exact part where it is mapped out, that part on its representation on the brain is going to affect its physical representation on the what? On the body. Why you're going to find others are going to either block the flow of that water within the what? Within the brain, and will present you with symptoms of headache, dizziness, and you'll find that you develop a condition you'll say probably hydrocephalus. That would also, which is now that becomes an acutely life-threatening, that has to be sorted out immediately before even you think about the tumor, unless you can do it all in the same setting, that when you remove the tumor, then sort out the what? The hydrocephalus automatically. But if it cannot be happen, then you probably even have to sort it out what? Immediately. So others you would have eyes moving up and down, nystagmus, or something like that. You could even get all urinate on yourself and so on, which is, it gets really what? Embarrassing. So if it gets down to the spinal cord, you could have pain, radiating pain to your legs or hands, or weakness that is occurring within the spinal cord. Then, as we talked about, children become a specific group. The ones especially that occur in the posterior part of your brain. You'd find they cannot feed well. When you try to feed, the child is still choking, and you're always treating pneumonia. Because other than the food going to the stomach, it's instead going into the airway, because the child cannot protect the what? The airway. So you end up is always choking, and you're taking pneumonia after pneumonia after pneumonia, or something like that. So it becomes something very what? And then you could even have failure to thrive for the young children, like they are failing to what? To grow. Enlarged heads. Sometimes for in the adult patients as well, since the brain also produces hormones and so on. Hormones are a means of communication between where it's being produced to any other part of the body. If it's, let me say, growth hormone and you're finished growing, all your joints, hands, you become a very gigantic.
Because the growth
jaw
hormone is
becomes
too
big,
much.
your tongue becomes big, or if not, if you're a woman or even a man, if you have some other hormones which aid in milk production, then you start having abnormal milk production. So it's dependent on what exactly at the time is being what? Affected, and where its location. Could be posteriorly, your vision is gone. Some patients, it may not actually be even affecting the visual area, but just the pathway of where you're seeing from is affected, and you start having scatty, spotty looks all over your visual, where you're supposed to be seeing, but you start having scanty looks, or you lose your sense of smell. So all even your hearing, some affect the hearing pathway. So your representation of hearing, then you start having impaired hearing from one ear, especially if like the neurofibromatosis that they talked about, you find a swelling on the ear, you're not able to hear.
Wow. Thank you very much, Dr. Okirol, for taking us through the signs and symptoms. Like you've mentioned that the brain is the controller of all the activities that happen in the body. So depending on where the tumor is or the mass is, symptoms will come accordingly. So if it affects a place which is responsible for hearing, somebody could have visual impairment. You mentioned about things like headache. And then you also told us about convulsions and seizures. Most of our people, whenever they see seizures, they think someone is bewitched. But it's quite important for us to know that actually sometimes it's a medical condition that maybe causes this. Thank you very much, our beloved viewers, for keeping it a DOCtalk show. Just to remind you that this program is brought to you by the Ministry of Health, as well as the Cameline Men's Collection, who have the best suits in town. And if you have any feedback about this show, please text us on our WhatsApp numbers that are right there on the screen. We are going to take a short break, and then we shall be back and talk more a little bit about this condition, brain tumors and the swellings.
You are watching the DOCtalk show. This message is from the Ministry of Health with support from partners.
Mikolo Business Expo kumipira bili mwetano ine komyewo wakati wena zomezi mwenda paka 11 Mei lugugu uma showgrounds event service providers naba business endala zonna mwandu bademwa yuna Mikolo Business Expo kumipira bili mwetano emidala jiri kumitwalo nkaga ino bronze mitwalo chinana ku silver ate gold yakakadde kalamba kogata platinum yakamuchi tundu okuyingira Mikolo Business Expo kumipira bili mwetano kwa 15 zokka kati wasasula omudala osasuulidde ekifo tenti emmeeza entebe bbiri kwogata amasannyalaze ne security okumanya ebisingawo kuba 0701 620 292 oba 0776 620 292 biteeddwa mu ssente Photogenics Limited, Lean Events, Crane Performers, Chabasa Pharma, BBS Telefina, UBC, Rosie Roots, City Bridals, Joyce Sonko Textiles, Channel Ladies Choice, Njuvu Estates, Junico Rio Deco, Victory Travel Center, Tender Gardens, Eco Farm Pharmacy, Mikolo Magazine, ne Pepsi.
You are watching the DOCtalk show. This message is from the Ministry of Health with support from partners.
Welcome back from that short commercial break. We are continuing the topic of brain tumors on this DOCtalk show, where I bring you real doctors, experienced, qualified, compassionate about the topic, talk about real solutions to your problems. This program is brought to you by the Ministry of Health and Cameline Men's Collection. Now, doctors, I want us to talk about the diagnosis. How do you know that actually this person has this brain swelling? Or maybe how do we know that this is cancerous, this is not cancerous, this is in this position? Dr. Okirol told us that these masses could be anywhere in the brain. So as doctors, how do you know that, this tumor is maybe in such and such a place? Dr. Juliet.
Thank you very much. One of the most important things in medicine is the history and examination. For us as neurosurgeons, usually you'll hear what your patient is saying as they walk into a room. You'll see how they are walking and you definitely know that something is wrong. It's quite rare for an adult to come in with a seizure if they've been okay. It's quite rare for an adult to come in one morning and say, I've had weakness on this side for 3 months without a fall or anything, and they are not hypertensive. So it is very important for us to know when and how it all began. And most of the times when we ask these questions, we then will send you to check the brain. Blood may not be very important for us to check the brain, except when you're producing more hormones than usual. So patients who come in with the tumor of the hormonal gland usually have vision issues, and then the hormones are raised. So usually when we check your blood, when we check your eyes specifically, we'll see that you're losing vision. In fact, the paper will come back and we'll see that you've lost vision. There are patients who have actually come from the eye doctor to us to check, and for sure you found that they have something. There are those that come from the ear doctor because they went in for an ear check and then they found that they were not hearing well. So sometimes those are the initial things that we do. So for us as neurosurgeons, the first thing we'll ask for is a brain CT scan. At this point, we want to inject you some medicine so we can see what you have in your brain. So when a doctor tells you that we will inject you with some medicine, it's just to show us what is in the brain. And usually when we inject it, if you have a tumor, the tumor may take up some of that medicine and actually brighten out. There are some tumors that may not take, but still we'll see them.
Is that what they call the contrast?
Yes, the contrasted brain CT scan. Sometimes we do brain CT scans and they are not clear. So there are some patients who come and tell you, but why did we do the CT scan? The CT scan is done because it shows bone better than the MRI that most people want to do. And then the CT scan is cheaper because outside Kampala, not so many centers have the MRI. So if someone is in Masaka, the first thing they'll do is a brain CT scan. It's cheaper, it can be easily done. So now the brain MRI usually shows us now the clear picture. You'll see the brain, even someone walking on the street will know that this is my brain. And so it delineates, it shows us where the tumor is. And then it also helps, they both help us to plan because you can't do anything without seeing what they are. You can't go anywhere in the brain without mapping. It's like a GPS anyway. Then there are times when we go to remove brain water, especially when it's a lot. And sometimes we may check it for tumor cells. There are times when we still get off that water or create a pathway for that water other than the normal, because if the normal pathway is blocked, then you may create a new pathway. But in that setting, we may also pick off some of the tumor, and that may be faster because there are some tumors that once you confirm it is, treatment may start as soon as the next day. And then, of course, when we operate, that is also part of trying to say, okay, I'm trying to find out what it is. So when we operate, we take off tissues, samples. And I know that we've told patients that please take them to several labs because sometimes the surgeon knows what they have and then you may not get the right answer. And you want to make sure that you get the right answer and actually treat it. So that which we call histological diagnosis actually gives us the answer. And commonly in Uganda, this is the one that gives us the numbers. So for most of the labs that we have in Uganda, they'll give us what the tumor looks like, and then they give us the numbers. Now, once we get the numbers, if you're 1 and 2, we may say, okay, we shall watch you closely. If you're going to 3 and 4, that is when now we start saying, okay, maybe you need more management.
Wow. Talking management, I think Dr. Okiro should pick up from there. If somebody comes in with symptoms like you told us and you've done the workup, doctors told us about the CTs and the MRIs and all these scans, and then you've confirmed that somebody has a brain tumor, how do you go about it? How do you address that problem?
Well, with the management of brain tumors, this is done in at least Mulago National Referral Hospital, Mengo Hospital, Mbara National Referral Hospital, even another PNFPA Children's Hospital. Those are facilities that can really help you in trying to solve this. Because most of them have qualified surgeons. So what is going to be happening is, here we are going to discuss what are the goals of achieving treatment with the what? With the patient. What are we achieving? Is it cure? Is it diagnosis? Is it adjuvant? So we have to be very clear with what the aims of surgery is, because surgery is an invasive procedure. So after discussing this with the patient, then that's when we have to do it to go ahead with what you suggest with the patient, because here we are looking at if it is a low-grade tumor, the ones we've talked about, grade 1 and grade 2, would achieve what we call a maximum safe resection. Those are important words. Maximum meaning we take as much as we can. Safe meaning as much as you're taking as much as you can. You should make sure you have the patient's interests at heart, that you do not want to create any other problem. You don't want to create a new problem to the what? To the patient. So you want a maximum safe resection. If it gives you the ability to have a total resection, great. Patient will not need any other treatment modality and so on, because if it's a grade 1, that should be almost a curative, or the chance of it reoccurring may drop as low as 9%. Okay? If it is not, and because probably it's involving very important critical structures, then you might just, what you do call debulking, to reduce the symptoms, the things that reduce the pressure in the brain and the symptoms it was what? Causing. If it has become, so that is going to guide you. So on top of that, if it is a higher grade tumor, then probably you would want to be what you'd call a multidisciplinary team management. That's why we have things like a neurotumor board to try to discuss on after removing this tumor for us in the surgical side, in the medical side, and the radiation oncologist. What can you offer? Can they offer radiation to the patient? Is it safe at the spot where you're radiating? Remember, the brain is a small structure, but it has the entire body mapped out. That means the whole entire body is mapped out into very small areas within the brain. So even if the radio oncologist, if I direct my radiation there, is it going to affect other structures? Will I affect the seeing of this patient? Am I going to affect hearing of this patient? Depending on where it is located. So those are things, other factors you do. Sometimes you could present also like extremely late and we'll tell you that, you know what, whereas this management is there and so on, but you're not going to do what?
You're not going to cure, you're not going to get complete
you're not going to get benefit from it. It's better you undergo variation. Also, no surgery is also an option, and the management option for this kind of patient. So it is a case by case, depending on what tumor it is, what grade it is, what are the goals of the surgery, its location. Those are things that have to become very clear in your discussion with the patient, so that you have a very clear plan. And after that, you will probably have follow-up imaging. Then initially, it might be a frequent imaging, but as time goes on, it may become a one-off to see, is it regrowing? Is it subsiding? Okay. Do you need to go back for chemo or not? Can we, if it reoccurs, can we go back for surgery or not? Those are things that it's a continuous interaction between the doctor and the patient. And the patient.
Is that why when you discharge these patients, you usually tell them, you give them a review date that come back after such and such a time?
Yeah, well, one of the disciplines that you will find that we really hold on to patients with slightly longer duration than most other disciplines, because this is almost a journey that you go to travel, because I don't think any one of you're comfortable having your brain open and everything, but by the time somebody trusts you to open up their brain and so on, it is a journey that you go to walk with the patient, which needs utmost honesty with the patient, and also the patient being honest to you with what they want to achieve in their treatment.
Wow. Thank you very much, Dr. Carol, for that wonderful description of the management options that are there. Like you've mentioned, when the diagnosis is made, partly there can be some room for chemotherapy, depending on which cancer it is. There's a room for surgery, there's a room for radiation, and there are some cancers that you really can't operate and you just have to give palliative care, whereby you're going to help this person live comfortably, live pain-free, and so that they have a good quality of life. Thank you very much, our beloved viewers, for keeping up to DOCtalk show up to this moment. Yes, in studio we have Dr. Juliet and Dr. Kirol, and we're talking about brain tumors. This program is brought to you by the Ministry of Health and Cameline Men's Collection. And if you have any feedback that you want to give us about this program, or you have any questions, or you have any topics that you think we should discuss about next time, please reach out to us on these numbers that are right on your screen. We're going to take another short break, and we shall come back and complete this program. Thank you very much.
You are watching the DOCtalk Show. This message is from the Ministry of Health with support from partners.
Looking for instant excitement? The Uganda National Lottery Spin for Cash game is now available online. Wherever you are, you can join the excitement for just 500, 1,000 and 2,000 Uganda shillings. Don't miss out. Register now on www.nationallottery.go.ug for a chance to win your share of 2 billion instantly. What are you waiting for? Play Spin for Cash now, anytime, anywhere. Ituba is the proud operator of the Uganda National Lottery. Uganda National Lottery. Dream, play, win. Participants must be 18 years or older. Play responsibly. The Uganda National Lottery is operated by Ituba Uganda and regulated by the National Lotteries and Gaming Regulatory Board.
You are watching the DOCtalk Show. This message is from the Ministry of Health with support from partners.
Well, welcome back from that short commercial break. We are on the DOCtalk Show where medicine makes real meaning, and you're having these two neurosurgeons, super specialized, but it's not easy to become a neurosurgeon, and they have told us about brain tumors. We've seen the signs and symptoms, how they make the diagnosis, and how they manage the patients. Now, I want to ask you, doctors, what have your experiences been taking care of these patients? What are some of the challenges that you face in this work that you do? And maybe you could also tell us about the quality of life for these patients after you've done all these procedures. How do they live out there in the community? Starting with you, Dr. Juliet.
So, there are several things we've noticed. Experiences, of course, the patients are there. You can't say that I've not seen the patients. They are there. Of course, when you compare Uganda and elsewhere, it's totally different. Of course, you see this patient, they usually come in late, and coming in late, very big tumor, they already have symptoms, and the bigger problem we have is that you don't have one or two that are coming in. There's a ward round you will do and you have 3. There's a week you'll see almost 8 patients with brain tumors. And of course, managing a brain tumor patient is not like managing an accident patient. An accident patient, you take them to theater, operate them, tomorrow morning they'll have breakfast. A brain tumor patient takes teams. You're looking at the anesthesiologist, the nurse, the intensive care unit. And in our setting where we have mainly trauma, the head injury is taking over, you may find that the availability of intensive care unit is also itself a challenge. And now when you start comparing the other nations, there are nations where once a patient is seen, yes, they are booked, but they are called on as early as if the symptoms are getting worse, they are called on, operated, and then they would get better. However, of course, even out there, there are some nations which also book longer, like 6 months, 2 years. So it's not new, but some of those challenges of the long waits. So sometimes you may call back family and ask them, is this patient still alive? And they've already passed away when you've not gotten a chance to actually operate them. Yeah.
Well, thank you very much, Dr. Juliet. Yes, Dr. Kyo, pick on from there. What have your experiences been?
The experiences with brain tumors has been one of a journey. Is whereas patients And most of our patients, honestly, present in the later stages of of life. But at least we appreciate that probably with the adoption of imaging within the regional referral hospitals, more will get to be detected a lot much more earlier, other than thinking that probably the patient suffered a stroke or something like that, because it's a common thing that people have been thinking that it's happening, yet could be something else. I think that was going to ease out with the diagnosis of the disease. Then two is, as we talked about earlier, it's a multidisciplinary neurosurgery is a multidisciplinary approach thing, because we said, what are your aims, targets, and goals? So in all this, there are very many teams that you need, right from the nurses, the doctors, the neurosurgeons, theater team, intensivists, the ICU, rehabilitation, because even after surgery, you need rehabilitative places. Otherwise, especially when a patient presented when he's already weak on one side or something like that, you end up having a stiff limb. So if the rehabilitation is not on good scale, then probably it's got to have non-desirable outcomes, as you probably say, functionality. And then the follow-up of these patients, because we do not really have a direct database that we really follow up on after 5 years, how are they doing, or something like that. So it's something that we can always aim at improving on ourselves.
Wow. Thank you very much, doctors, for sharing your experiences. And right now, I think we shall be making our parting shots. But before that, I want to remind our viewers that this DOCtalk show is brought to you by the Ministry of Health and Cameline's Men's Collection. And I remind you that if you have any comments, please send us your messages on the numbers as you can see them on the screen. So, doctors, as we're trying to conclude this show, I want you to tell us your parting shots. Now that you've seen that most of our patients come to us late, and usually when the cancers have advanced, what advice do you have for them, and maybe what can they do to ensure that they don't come late, and maybe is there any prevention that they can do to ensure that they don't get this condition, starting with the doctor?
Well, with this at hand, if I'm to think about what can we do, we've already talked about the imaging that have been put at the regional referrals, and then two, we have to have an attitude change from superstition and thinking of other alternative medicines. Go seek help from a qualified medical personnel so that you're helped in a timely fashion. Sometimes you have what they call time is brain. The more time you take, the more brain you're losing out. So the earlier you help out to do this, the better your outcomes, and the things are not alien to the country. They're being done within the within the nation. So I encourage people to, when you have problems that you don't seem to understand, always seek medical care. Can always seek a second opinion. There, I've told you, very many facilities to offer the services. At least you have the National Referral Hospital, you have Barara, you have the PNFPs of Mengo, you have Cure there. Even you have the regional referral hospitals now. You have people there who are really qualified to do it, to help you out. And if you need any referrals, they can always execute that and you'll be helped.
All right. Thank you very much. Yes, Dr. Juliet.
Yes.
Your parting shots.
So, for me, I think more of utilizing what we have. Recently, as we celebrated the Neurosurgery Day, I kept looking back at there are hospitals we have that can debulk big hospitals. We have Chirudu, we have Naguru, we have Kawempe, probably not, but Jinja, Masaka. So the beautiful thing is that there are 7 neurosurgeons now trained. And because there are 7 neurosurgeons now trained, the spread out. Neurosurgeon, intensivist, anesthesiologist spreading out into those other hospitals, so that there are some of these cases that tend to take a bit of our time. Those can be sorted there, and then we spread out this giving care, because giving care to the tumor patient. Tumor patients are very demanding. Like Dr. Kirol has said, they need teams. I may operate today, but the intensivist is going to be, needed. The oncologist is going to be needed. So they demand that time. So I think special dedication to Mbarara, Cure, Mulago, to these patients, I think will cause such an impact for them. Like we've said, time is brain, brain is time. They don't have so much time. And maybe the reason we lose them to follow up is because maybe some give up. But once we dedicate our resources and say, for sure, tumor patients, go to Mulago, Mbarara, and then you know that these hospitals are just specific for these. Management will also get easier.
Okay. Wow. Thank you very much, doctors, for sharing with us your experiences. From this conversation, there's so much that I've learned, and I believe our viewers out there, you must have learned a few things. We've seen that most of the times patients come to us doctors late, and it's quite imperative that you start coming on time. If you're getting these symptoms, you're having this headache that doesn't go, you're having these seizures, it's not that maybe someone is bewitching you like most of our people think. People actually get these symptoms, and instead of seeking medical attention from qualified professionals like the ones on this panel, many of you tend to seek alternative care, and usually by the time you come to us, it's quite late. We've also seen that getting this diagnosis is not the end itself. There's so much that can be done. Surgeries are there. Many people actually don't know that we have actually surgeries here. Whenever they get these conditions, they think about flying abroad. But actually, we're having these services here. We're having the specialists here. The theaters are there to take care of you. So should you have any concerns, some of the symptoms like doctor mentioned about them, it's better you seek care quite on time so that you get the treatment and live a good life thereafter. So we've come to the end of our show. Thank you very much for being a great audience. I just want to remind you that this program is brought to you by the Ministry of Health together with Cameline Men's Collection. They have the best suits in town, and if you need a suit, you need to look good, please check on them to get these suits. Thank you very much for being a good audience. Catch us next Thursday at the same time, the same show. See you then.
This message is from the Ministry of Health with support from partners.
UBC